It was a great first half of the afternoon there with the cases. Now we're going to get on to a couple of short talks, and then we'll get to the Schwartz lecture. It's my pleasure to introduce the first speaker of the latter part of the afternoon, who's my partner, Tony Bottiggi. Tony was born, I think he grew up in Lexington. His father's a local pediatrician.
I grew up there.
Spent a fair bit of time
North, but yeah.
Went to undergraduate at SUNY in Binghamton and went to medical school at SUNY in Buffalo. Came here to do his general surgical residency. He was my intern when I was a third-year resident at the VA, and that turned out okay. He stayed here to do surgical critical care fellowship and then went into private practice in Louisville and also did EICU, virtual ICU, in Louisville for a time before coming back here, joining the trauma faculty, and having a part-time appointment at the VA. Tony's risen through the academic ranks, is now Associate Professor of Surgery, is Medical Director of the Surgical ICU at the VA, is heavily involved in surgical quality at the VA. His big interest is in EMS. He's an EMS Medical Director and has developed a keen interest in tactical EMS. He's been nominated to the Kentucky Board of EMS. So Tony's going to talk to us today about tactical emergency medical support. Tony?
All right, thanks. Is this on? All right. I just want to say a couple words. This is the Schwartz lecture. A few current residents, unfortunately, did not have the privilege of working with Dr. Schwartz. I was president here from 2000 to 2005 and a fellow. I got to know Dr. Schwartz pretty well. He was a good mentor. And he and Dr. Sloan were instrumental in me coming back. I already knew, the blue guys when that job opened, but, I got honest answers straight up about what's going on at the VA. And he's always been a good go-to person, no BS, straight to the point. And I've always admired him for that. And the other thing that made Richard and Janet very special to the residents is every year after the AB site, they would invite us over to their home just to have a, decompress, have a good time. And, Janet, that's something we still cherish and remember and appreciate that as well. So it's my honor and privilege to be up here to talk about something probably most of you don't know anything about. It's going to be a little long. I'm going to try to speed through it. I'll try to keep it a little interactive and entertaining here. But talk about tactical emergency medical support. I tell people all the time, I'm on SRT, special response team. People are like, well, what is that? Well, there's multiple names for it. SORT, special operations response team, rapid response team, RRT, fast action support team, Fast Action Response Team, FAR, well, that mnemonic doesn't work very well. But most people recognize Special Weapons and Tactics, or SWAT. So that's essentially, SRT is SWAT, and it does its job of toning it down. So when I say SRT, people are like, what? Versus, hey, I got, SWAT training today. So as Andrew said, Woodford County EMS medical director, raise your point. They were needing somebody. And long story short, I knew the assistant director, getting into the TEMS field, so he got me on that. And then part of the duties of that is being the medical director for the special response team. And after being on the team for a couple of years, they swore me in. So yes, this is not cosplay. This gun's real. This badge is real. But just so you know, I checked with Dr. Sloan, Dr. Bernard, UK Police, and legal, saying, hey, I'm showing up like this. And the reason why I'm like this today, it happens to coincide with my training day. I'm leaving here straight to training, so it just happened to line up this way. So, all right. So, what are my other qualifications, and how did I get into this? I met Bill Schmock at the Trauma Symposium several years ago. He's on the Louisville SWAT team out there. One of the ER docs, talked to him. Julia Martin was there. She forwarded me something about a training program back in 2015. So I took combat casualty care as part of a TEMS course. It was a good 40 hours is an entire week course where it was lectures, tactics, and then TCCC, and then hands-on in the field care. So by definition, what is TEMS? It's hard to read here, but the National Tactical Officers Association, this is their definition. It's the mission, pre-planning, preventive care, and medical treatment rendered during mission-driven, high-risk, large-scale, and extended law enforcement operations. TEMS scope of practice includes medical interventions that further the health and safety of all law enforcement personnel and is intended to reduce the incidence of injury, illness, disability, and death associated with police operations. TEMS adapts and incorporates sound medical practices with police tactics, for use in operations characterized by competing mission objectives, diagnostic uncertainty, limited resources, and performance decrement under stress to permit the delivery of effective medical care and unfolding law enforcement mission. So essentially, on the medical support for the SWAT team. The goals of tactical emergency medical care, enhance mission accomplishment. Well, everybody has that role. Prepare medical threat assessment. I'll go over that later in the talk. Monitor the medical effects of environmental conditions. Today not a big deal, but last month it was 90 degrees. Looking for effects of dehydration, et cetera. If it's cold and wet, watch out for hypothermia. Tell the tactical commander what's going on. That may change the timeline on a call out where you're going to sit and wait or you're going to go ahead and take care of business. This is the part I hope I never have to do, is try to reduce death and injury and illness related effects among team members, innocents, and perpetrators, but I'm there for the officers in the event of the unfortunate, and you're all familiar with, I'm sure, with Scott County 217, who was recently admitted. So hopefully I don't have to do that for Woodford. And reduce lost work time if I keep somebody from getting injured or going too far and hurting themselves, not on workers' comp. This is probably the main thing I do, is maintain good team morale. They think by having me around, it gives them just that little bit extra edge. In reality, am I going to make that big a difference in the field? Probably not, but if I can give them that 5% extra chance of getting home to their kids, they really appreciate that. Maintain health and preventive medicine, not tweaking their blood pressure meds and stuff like that, but just watching out for things that can get them acutely ill. Coordinate with surrounding agencies and hospitals. Well, here I am with UK and the trauma center. Decrease liability, for both the law enforcement and citizens, and possess basic forensic knowledge and crime scene preservation. Essentially, don't touch it, don't do anything. So why do we need towns? Why should we care? I mean, unless you live in a cave, you kind of watch the news, lately. But I just want to let you know that this isn't something that's suddenly brand new out of nowhere. How safe is your school? I Googled this, found it on the internet. And they say also school shootings are becoming more common. Myth, I'm not going to get into that, but let's just say the perception is becoming more common. You should never expect it to happen at your own school. Threats have happened at Shenandoah, but thankfully it's never more than just a threat. What a lot of students don't know is, however, back in 1990, a discontent student named Greg Oswit entered high school east wielding a shotgun. Well, Columbine is 4/20/1999, so that's already 9 years before Columbine. Everybody knows Columbine, right? So this is not something new, but some of the themes are the same. And one of the monitors remembers it. The shooter came into the front door, walked right through the halls and the courtyard. It's where the principal was able to convince him to drop the shotgun. I think there's more to the story than that. He was not happy with certain students. He was looking to kill certain friends, quote-unquote friends, so that theme continues today. Specific targets in mind. He was convinced to turn himself in, etc. Nobody got shot, nobody got killed. They didn't hit all the media and all the mass hysteria we have, but that's 9 years before Columbine. Obviously, I'm not going to go over Columbine. This is a picture of Mr. Oswit here getting taken off. And people say, all right, let's just ban guns. That takes care of the problems. Well, in China, just recently, this spring, 9 kids dead, 10 injured with stabbings. So, banning knives is an idea that doesn't seem to work. This is not a fake, article here or some type of parody account. Other reasons why we should care, if you've watched the news lately, there were these people out in New Mexico that were planning a terrorist attack. They found out it was actually going to be a hospital. It was actually going to be Grady, not even in their state. So they're targeting trauma centers. So if you're thinking about where to cause mass chaos and disrupt a trauma system, we'll go after the center. Well, has there ever been anybody here in Kentucky that might cause some disruptions? These guys, Bowling Green, they were actually helping Al-Qaeda in Iraq, but now that they've seen these ideas, monkey see, monkey do, we could be potentially at risk for an attack here at UK. Hopefully that doesn't happen. Just a matter of time. There was a shooting in Marshall. This was in the spring. This was a disgruntled student thinking about going up and shooting up Dunbar. So this is real. It's getting close to home. There's no way to legislate evil away. It's, a lot of you are too young to remember, but prior to 9/11, the biggest mass killing and terrorism in the United States was done with a white van and fertilizer. It actually killed more people than the Las Vegas shooting. So you don't need a gun to take out a lot of people. Why do I care so much about this? I wasn't at Columbine. I wasn't at Virginia Tech. I wasn't at Parkland. But I am class of Shenandoah in 1992. I was a sophomore the day that this guy came in. So that left a little impression on me. So this is kind of my passion, my interest is preventing these things, and realize it happened to me, it can happen to you, it can happen again. So moving on from that, what is the basis of care for tactical EMS? Well, a lot of the things in trauma we get out of the military, tactical combat casualty care. The civilian is tactical emergency casualty care. Like I said, I took that course at the beginning. I'm going to talk, I can't cover TCCC. I'm just going to give you a quick rundown on this and then integrate that into how we merge the tactics of medicine and police work. So in terms of zones, the cold zone, safe environment, no threat to safety outside the perimeter. The shooter cannot get a bullet in a straight line to you. Regular EMS principles apply. The warm zone, the threat's not considered imminent but still exists. Somebody could pop out of somewhere and ambush you. The hot zone, the potential is real. The shooter's active or is barricaded in a certain area. And the Hartford Consensus, which I hope you all are aware of, it's put out by the American College of Surgeons, breaks down the zones as well to the hot, red, yellow, green. And what they say is, so if you can kind of compress those zones down and get some overlap, you can save lives and get earlier hemorrhage control. There's 3 phases of TCCC. First one's care under fire. This was where airway, C-spine precautions, CPR, they're deferred. I mean, rounds are coming at you, or they're getting close. You're just trying to get the cover. Extremity hemorrhage is a priority. That's the number 1 cause of preventable death in Iraq, Afghanistan, and theoretically in the community for mass shootings. Tourniquets are key, and you try to encourage self-aid if possible to try to free up your hands, etc. Mitigate the threat, suppressive fire. And place patient in a rescue position if you can't, get them out of the way, which is on their side. And evacuate the patient to a safer location as soon as possible. And then that takes you to the second aspect, which is tactical field care. This is medical treatment occurs in the warm zone. It can be just a matter of dragging somebody around the corner in an area of cover. And cover is not the Hollywood cardboard box that magically stops bullets. It's around a hard concrete wall. Airways addressed here, it's 1.8 cause of death. All those patients had penetrating injury to the face. And if you can't get the airway, it's, you don't monkey around with, intubation straight to crike. Breathing, a pneumothorax, tension pneumothorax, 3 to 4%, all potentially preventable battlefield deaths. Sucking chest wounds. So why would we care about something that's so low percentage? Well, it happened. A KSP detective was shot in a pot field out in the hollers somewhere. Took several hours to get help to him. Other officers were there. Felt helpless. They couldn't do anything. Coroner's cause of death was tension pneumothorax. And this was a 100% preventable cause of death. So very unfortunate, although 1981 EMS is a little rudimentary, but our goal is to get rid of all of these. Tactical field care. Once you're in cover, you reassess the bleeding. Do I need to adjust the tourniquet or reapply one? Do they really need the tourniquet? Hemostatic agents, this is your quick clot, the stop the bleed stuff. IV fluids only if they're in hemorrhagic shock, permissive hypotension, which I hope you guys are all familiar with. Hypothermia prevention, we carry on the big Mylar space blankets and stuff to start covering them up. Analgesia is important because they found that the more pain they have up front, the higher the rates of PTSD, and particularly ketamine can decrease that rate in the field. So TCCC endorses ketamine, the right way to use the word endorse. Prophylactic antibiotics, that applies more to the military, with long transport times, but potentially could be applicable in eastern Kentucky. Some of those far out fields, even in Woodford County, there's some remote areas that are, difficult roads, et cetera. You could be 45 plus minutes away and they don't have good landing zones for helicopters. Appropriate cardiopulmonary resuscitation, often futile in the field, but I've read that it's very important to the team that if an officer goes down, you do CPR no matter what. They want to see you doing everything you can as the patient leaves the scene. So, and if you don't, they have a lot of psychological issues, et cetera. So the caveat that is don't put people in harm's way unnecessarily. If somebody takes a round to the head out in the open, is laying there obviously dead or high probability of being dead, you're not going to send 4 more guys out there to get shot up either. That's a call I hope I never have to make, but it's one of the responsibilities that I may have to do. So combat casualty evacuation care is the cold zone in the safe area. Traditional civilian field care takes over. ALS en route to the receiving facility. TXA, as we're seeing now, it's, do we give it empirically? Wait on the tag. If it's a long transport, yeah, I might say, give it. Blood, some services, some of the flight crews have blood in the field. It's something I potentially could coordinate with Bluegrass, have some blood available if it's a really, really high risk situation. Tactical evacuation care, that's a little bit more focused on the military, but there's situations we may have to have our armored car ready to go in and scoop somebody up and go. So there's another acronym called the MARCH protocol. It's not ABC anymore. It's massive hemorrhage control, tourniquets, airway management, usually very basic unless somebody needs a crike, which should be rare. Respiratory management, needle decompression, finger thoracostomy has been mentioned, although that's a little bit, that's not your basic paramedic skill. Circulation, bleeding control, the fluids, hypothermias, often overlooked. We do it routinely here, but you got to think about it in the field. Head, eye, and then everything else. Just a quick word on tourniquets. I gave a talk a few years ago on that. But say somebody's shot up on one of the floors for bed. We don't have tourniquets up there, and how long you think it'll take to get one from the ER. So you may be called upon to improvise a tourniquet. And this has happened at hospitals. Somebody got shot. There were no tourniquets to be found. So improvise versus commercial. Obviously, if a cat, use that, but it should be wide enough to compress the vasculature without causing excessive pressure, so don't use a piece of paracord. Use some Curlex or something. Should have a mechanical advantage, such as a windlass, avoid a venous tourniquet, crank the sucker down tight. Can be as effective, although in reality most of them failed. The Boston bombing is that famous picture of the guy with the cowboy hat and the belt. Every improvised tourniquet in Boston failed. None of the police had commercial tourniquets, and none of the EMS did either. Guess what? They do now. So it's not the way you want to find out you need them. They can't cause more pain, but who cares? But here's how you put one on. So you have to use one. Use a wide bandage. Wrap it down. Tie your windlass in there, which would be a rigid, stick or pin. Crank the sucker down and then secure it. The old belt. It's going to be worthless. So there's my 2 cents. Hopefully you never have to use that. So what's the what's the appropriate response to mass shootings? Well, there's something called Rescue Task Force and something called Tactical Emergency Medical Support. Obviously, this is my talk, but this is closely integrated. They're similar, but a little bit different. And why is this so important? You think we'd learn from lessons past. Unfortunately, sometimes we don't. You all remember the Pulse nightclub shooting. I remember it. I was at Disney with my family last week. That was the initial target. But due to security, the guy went to a softer target and shot up this nightclub instead. So a lot to read here. So a lot of criticism. Unable to implement active shooter policy and supply its firefighters and paramedics with ballistic vests. Hey, we should get these things. That's a great idea. Didn't get it. Needed it. Reporting this delay helped to... This reporting says this delayed help to the wounded. Claim Orlando's leaders continue to dispute. Of course, the politicians are not going to take the blame. 49 died, 53 injured in the attack. A study this year said as many as 16 could have been saved if they received basic care within just 10 minutes and to the hospital within an hour. So we're talking a very fine window to get to these people. So any bureaucratic delay or we're not familiar with this, it's just not going to work. And their answer was, we're not prepared to go in the hot zone. That's just not what we do as a fire department. It was active shooting. Not everybody, felt that way. They said they did drills. It wasn't enough. They said they didn't have formalized training. Well, shame on you. You should have. We didn't have a policy. We didn't have procedure. We had the equipment, but it was locked up in EMS in a storage closet. And unfortunately, we were, a day and a dollar late. It's like the Titanic. They had enough lifeboats. They decided not to put them on the Titanic. So let's not keep the ballistic vests where they're actually accessible. So the timeline was at 2:02. They started shooting. Police officers come out of the woodwork. Officers went inside to go after the shooter. Almost 20 minutes later, they tried to come up with a way, how are we going to get people in there? They couldn't figure it out. A few minutes later, they're asking for fire department to come in. And the Justice Department said that's the time they could have gone in, yet the fire department was not allowed to enter. Like I said, there were, 50-something deaths, from that event. 2:50, the shooter threatened to blow things up. And remember, the shooting started at 2:02. It's 2:50, they're still not in the building. People show up. They actually finally brought the ballistic vest to the site. And a pure bureaucratic, answer, they were not allowed in because the paramedics hadn't been trained on how to use the vests. That'd be the same equivalent as saying you're in a sinking boat, you've not been trained to put on your life vest, we're not going to let you wear it. You put the damn vest on. There's no magic to it. Deja vu. Similar story. They're frustrated. On the Parkland. So this is just within a year or so. Same state. You think they would have come up with some protocols. A rescue task force presented at the commanding officer of Broward County Sheriff's Office. Request denied. The type of response was not appropriate at that time, since the location of the shooter was not known. They said RTF can be employed only when law enforcement can clear an area for EMS. I call absolute total BS on that, and I'm going to go over what you're supposed to do here in a minute. When they said medical teams are willing to risk their lives going in the scene, the commander said, pretty much no. And once again, people are willing to say, we're willing to go in there, risk our lives. And they're told, no, don't go. Paramedics asked 6 times to enter Parkland before they were told no every time. Cruz is finally caught around 3:40. He'd actually left the building at 2:21. So that's an hour and 20 minutes later, and they still would not let the fire department in. Their response was, SWAT medics went in instead, although nobody knows how many or what. They said it wouldn't have changed anything. Now, the paramedics are saying, they're not saying RTF would have made a difference, but you never let us in, we will never know. But going back to the Pulse nightclub shooting, just 10 minutes is what they said would have possibly saved some lives. So I'm going to start going over what the appropriate response is supposed to be in these situations. So rescue task force, initially EMS personnel show up, rapidly deploy in the area. They're not tactical medics, they're the first arriving fire department. Security is provided by law enforcement teams that show up. If there's a shooting, you're going to have 100+ officers. If something happens here, there'll be 100 police here in 5 minutes. So you're going to have people ready to get these guys in. EMS is going to be out here quickly. SWAT team will be 30 minutes to 60 minutes before they gather and show up. So after review of shooting data, obviously the sooner you can get in there and stop the bleeding, the more the survival. The immediate threat is rapidly mitigated in almost all incidents well prior to fire EMS even responds. Well, not in Pulse, not at Parkland. Risk from active shooter incidents is very low in areas that are cleared but not secure. I'll go over that here in a second. Care is not initiated by the law enforcement teams. They can be trained but may create role confusion. Their job is to go after that shooter. If their fellow officer gets hit and falls down, they just step over them and keep going. The reason why they do that is they know theoretically we're coming up behind them to try to take care of them. And part of that's because it takes equipment and training skill set, and they have other responsibilities that they have to do. They need to be doing the tactical police work, so it's poor use of resources, having them carry patients, etc. You need personnel to secure key real estate, hallways, stairwells, large open areas, perimeter control. You have lots of officers everywhere. They're trained to move to the shooter, not initiate medical care. Tactical medics are not always readily available. A few teams are full-time in this state. I think maybe Louisville, and then KSP are the only full-time teams. They have a different dedicated job to do. Sorry, I'm kind of moving quickly here. How many medics on the team? My team is myself and then 2 paramedics, which is probably the most in Eastern Kentucky. There's some teams in Louisville area, but I'm the only one. I think I'm the only physician in Eastern Kentucky. There's a couple in Western Kentucky. So we're right here. We're the highest trained TEMS unit in at least several counties around us. So initial law enforcement response. They enter the building, move to engage the shooter. They hear gunfire. They have intel. They're to drive to that location. If there's nothing, they do a hasty clear and keep moving forward. Contact teams are clearing as they move down to the sound of the shooting, and this is where Rescue Task Force comes in. They start to come in behind into the warm zone. As this team's going down, they're identifying threats. They radio patient down here. They don't stop to start treating them. They'll notify there's somebody down here that needs help. They're going after that shooter. They're not opening locked doors unless they think there's a shooter in there, but they'll do a hasty clear of an open room. Hence the warm zone. Somebody could pop out of that locked door. Clear versus secure. This is where a lot of the confusion comes in with the police. Secure is secondary search. That's after you blitz through, you're going back, opening every cabinet, looking under everything, etc. Clear is just a quick, no immediate threat. Police training emphasizes the site must be secured. This is where the conflict comes in and why they won't let people in. It's not clear. It's not safe. So by the time you secure an entire large building like a school, it's too late. The quick clear at Marshall was several minutes after the shooting in Kentucky. The KSP guy told me it was 10 hours before they finally cleared it. They were x-raying every suspicious book bag, etc. So RTF works when resources enter quickly. This is not the, it's one of those stage and go type things. But if the police aren't familiar with it, they're not going to deploy it in a timely fashion. So they obviously weren't at Pulse. They obviously weren't at Parkland. So the initial response, I'm running out of time here, so I'm going to fly ahead here. But this is the initial response. Is law enforcement stages front and rear security. The firefighters with their ballistic vests or EMS are in the middle. They're getting escorted in. Those first teams are charging down through. They're coming up behind. So if there is somebody still lurking in the warm zone, it's these guys' job to take it out. And this is actually Las Vegas, the Rescue Task Force formation. You can see the officers here and the fire medics, they're stationing up there. Communications, it's usually police to commander, commander to EMS, back to EMS. It's kind of a triangle. PPEs, ballistic, hearing, eye, and then body solution, gloves, etc. Hearing is important. The decibels on those rifles the police are using are 160 decibels plus. That's outdoors. If you were to fire that off in here, you would definitely have some hearing damage. Knee pads, you're going to be down on your knees taking care of people. You don't want broken glass, etc. The equipment's different than regular EMS. It's just pure, rapid bleeding tourniquets, airways, basic King Airways, splints, etc. Versus, you're not bringing in oxygen. I'm not carrying a big explosive thing on me. No monitors, just very basic equipment. Get in, get out. Stabilize as many people as you can. Get as deep as safely into the building. Grab, remove, move on. Get out to the casualty collection point. And for the sake of time, I'm going to just kind of speed up here. So here's kind of the diagram of it. Like I said, the initial threat. Law enforcement's coming in. They're going after that shooter. It sounds of gunfire. They see him. They're going after him. They're stepping over wounded as they go. They let the Rescue Task Force know. They're coming up in the rear, and they're going to start to assess the damage, to treat and extract those patients in real time, not wait for everything to be cleared. This is the cold zone where the incident command is, and they can leapfrog ahead. Let's say it's a big building. It's a lot of time getting people out. It's not completely cleared. You get a casualty collection point. We ran this drill at Woodford School. The police setup was not a good one. We tried to explain you want a smaller room with preferably one door to have to guard, ground floor, window accessible, so the firefighters can come in and rip those windows out and you can start extracting people. So here's kind of the timeline here, how theoretically it's supposed to go. And you kind of compare what it's supposed to go to what they did in Pulse and Parkland. The initial response, you're going to start getting police showing up in about 4 minutes. That's going to be a long-ass 4 minutes if you're in that building, but that's the time it takes. Hopefully it's quicker, hopefully it's not longer. People are going to be running out of the building. Your arterial bleeders are going to start taking effect. You're going to start getting some, your bad arterial injuries are dead, 3 minutes, 3 to 5 minutes. You cannot save those individuals. Law enforcement is starting to speed ahead clearing. EMS is forming up, hopefully around 5 to 6 minutes. And we have people stationed all throughout Lexington, so that's theoretically possible as long as they're allowed to gear up and start getting in. Law enforcement continues to charge ahead, clearing. Rescue Task Force starts entering. You start going back to that march, massive bleeding, airway respirations, and then head injuries, and hypothermia, et cetera. So you got to weigh the risk-benefit of the rescuers versus the civilians. And I can tell you, everybody that's a rescuer says, we're going in. We will take that risk. So that's Rescue Task Force. TEMS is more medical conscience of the team commander. We're there for the tactical unit. We're there for the police. We're giving them that extra medical support. So when they go into harm's way, they know there's somebody right behind them that's going to take care of them. So it takes a certain amount of courage to barge into a room where somebody could be staring you down with a shotgun or charging up some stairs where you don't know if somebody's there ready to take you out. And at KTOA, they had the CERT team come in. The hit rate on somebody against a police officer is 66%. So if somebody decides to shoot at a police officer 2 out of 3 times, they are going to hit them. So knowing that, my hat's off to those guys that are the door kickers. Medical threat assessments. I don't know if I'll have time to get to that. I'd like to, but remote assessment methodology, medicine across the barricade. So this is when TEMS would come into, not just RTF. High-risk warrant, possibly the number one reason why we would get called out. High risk, the guy's known, felon, wanted for murder, etc. Close target reconnaissance, high-risk investigative support. Go back to the pot field at the beginning of my talk. High-risk large search area. There was a shooting. This guy ran into this neighborhood. We have no idea where he is. They closed down a perimeter. Then it's a slow, methodical search going in there. Obviously, barricade, hostage, incidents. High-risk prisoner transport, where you think somebody's going to try to spring this guy. High-risk short-term protection detail. We've had Pence and Trump here. Lately, thankfully, I did not have to get involved in any of that rigmarole. Terrorist incidents, other situations requiring TEMS requested by law enforcement. So 3 echo, enter, evaluate, evacuate. And then hybrid TEMS and RTF, taking the charge. I'm just going to skip ahead here. So this is kind of what the hybrid's supposed to look like. Hot zone getting charged in by the law enforcement officers, followed by the tactical emergency medical support, followed by rescue task force, 1, 2, 3, returning into the triage area. So like we said in the Hartford consensus, you are compressing those zones, hot, warm, cold, to try to minimize the time and the delays. Now I can tell you that's theoretically how it goes. When we ran the drill in Woodford, it was during the summer, school was closed, the entire police force was there, the entire fire department was there. We ran through it the first time. It was 15 minutes before they started letting the firefighters come in, because the police, certain ones were still locked into that, we got to secure everything mindset. And they had one of the guys from my team, being the bad guy with sim guns, and it was as close to reality as it can get, so they had to take him out before they would let anybody in. They said, no, that's not the way it goes. Ran it again a little bit better, and then ran it a third time. So by the third time, things were starting to get closer to the way it was supposed to go. So the bottom line is you can tabletop this all you want. You got to actually get out there and do it. I put this up just to see who's still paying attention here. That's John Wick, for those of you that live in a cave. So, medical threat assessment here. I think I'm getting ready to run out of time, but essentially additional jobs I have are to look for any medical threats, such as environmental, biological, chemical. You know, we read a lot of meth houses, carfentanyl's out there, and a popular thing is for the drug dealers to throw a big cloud of drugs into the officer's face as they enter in the room. So they're not shooting them, but the officer's going down in about 30 seconds to a minute, etc. Watch out for that. Some people may have exotic pets. You know, somebody may have a pet cobra or some crap like that, and you may want to order up some special antivenom. Actually, when in my class, the instructor said they raided somebody's house that had special vipers, and when they entered the house, the guy was charging down the hall at him with 2 snakes in his hand. So just, you know, be aware of that. Think of the crap we see in the ER, the stuff they see out in the streets. Is you can't make this stuff up. And I'm gonna skip ahead here a little bit. Sorry, I had a long talk, but you know, part of my responsibilities include, you know, coordinating with the helicopter, trying to pre-plan a landing zone should we need it, etc. Having the equipment to designate the zone. Try to come up with a pre-plan. Yeah, like I said, I could talk on this for a long time. I'm running behind on time. So my main goal is to be the commander's conscience. One of my main jobs is to kind of give him my opinion. He may say, no, you have to come up with workarounds, but I am not the end-all, be-all. This is not the cockpit analogy where anybody can call stop. I do not have that authority. It's his final decision. All I can say is, here's my recommendation against this. He can take it or leave it. The one time he kind of asked us our opinion, me and the medics, on something, and the team in general, but he was kind of looking at our opinion is, you know, not to get too much into tactics, but you know, there's the stack up with the guns down. Now the new thing is stack up with the guns up so you can get your sights on faster. Well, if you practice that every day, that's one thing, but what's the main risk between down versus up? If you discharge down, you shoot somebody in the ass or the leg. I said, you know, we can fix that, but if it goes off like this to the back of the head, organ donors, you know, the best case scenario. So we all decided that unless you're doing this every day, it's not worth a discharge into the back of somebody's head. So it's one of the riskiest things we do. Even though at Woodford we don't get a lot of call-outs, is our live fire range. You know, that's, you know, we have 14 guys lined up, turning, moving, and shooting. There's a lot of potential for an accidental discharge with lots of equipment. Safeties get clicked off. It can easily hit, you know, snag something and cause it to fire. Thankfully, we've not had one of those. It won't take once to shut us down. But that is definitely a known risk. So I'm going to wrap up here in a second. Another thing is medicine across the barricade. Somebody's hostage. You know, Cletus is angry, shoots his wife. She's on the ground bleeding. He doesn't know anything about medical care. It's kind of our thing to talk him through what's going on. Here's what you can do to try to help your wife. We're not the hostage negotiator, but we're trying to, you know, get things going. So this is kind of something that, you know, that we kind of practiced in my class, as well as like assessing in the dark, extricating, etc. Education's another thing that we do. You know, we've put I'm part of Kentucky Tactical EMS. It's a brand new nonprofit organization in the state. Our goal is to train and educate things such as Rescue Task Force and TEMS to surrounding counties to try to cut down the incidence of death and mortality and morbidity if in the event of a school shooting, et cetera. Like I said, it's just a matter of time. But if we can do anything to cut that down, we're going to do it. And I'm, you know, the medical director for this. We currently have 52 requests for training, 10 of which are TEMS, so that's 42 Rescue Task Force, 51 instructors, goal of 160. You know, one of our instructors is Les Fryman. I think some of you may know him here. He's one of the Kentucky Fire. You know, it's one of the big things we do. You know, me and the other medics, we put all the Versailles Police Department through Stop the Bleed. We're going to do the Woodford County, you know, Sheriff's Office. Next, there's been other requests from Anderson County, Scott County, et cetera. So teaching's a big thing. We just don't have the time and resources to do it. It says Kevin Combs, he's the instructor, very engaging guy. He's the one that, really developed my enthusiasm for this. This is one of our rescue task force. It's full moulage, as realistic as we can get it. You can see, there's your security in the back there, and he's making sure that's not a bad guy. And there they are going out, and I'm hoping somebody's going to tell this guy, hey, you're about to back into a pallet. So any questions?
Really interesting, very specialized area of practice. So we don't have time for many questions, but I can't help but wonder how many trauma surgeons out there are participating in tactical EMS and RTF. Do you have a sense for that around the nation?
Not as many as should. It's mostly emergency physicians, but as you know, Dr. Eastman in Dallas, he's actually a reserve police officer. He's on the SWAT team. Actually, one of the fathers of TEMS is Dr. Richard Carmona, former Surgeon General. I met him at Kentucky Tactical Officers Association several years ago. So as a surgeon, we should be involved. We should be part of it. Tactical combat casualty care is a subset of American College of Surgeons Committee on Trauma, right along there with ATLS. So yes, it is something we should take the lead in, and it makes sense. We know the trauma center, we know the resources. And the main thing I tell the team is, I'm not going to be able to do anything out there in the field, but how many times have we had that patient come in and code in the ER, or 2 minutes out from the ER, or as soon as we hit the OR table? If I can do anything to cut that time down, EMS calls in all the time, you're going to need to go to the OR. How many times do we actually activate the OR? Where if I call the OR, or I call the ER and say, we're coming in with a red, greet them, get a medical record up there now, and I call the OR and say, we're coming in with a red straight up. I've already done a fast. Yes, we do have an ultrasound machine. Get x-ray up there in case we need it. We're coming straight up. That may cut down some of that time. That may give them just that little extra edge. And just them knowing that is their morale boost. So, and
Well, thank you for your service. Be careful out there.
all right, thanks.